How physician-assisted suicide leads to death with indignity. It's very important to understand requests to die. The motive for hastened death is hard to assess in a patient. You can't simply assume when a person says, "I want to die," that he or she is saying, "Kill me." There's a lot of complicated psychology here. The motive could be a cry for help. It almost always is a cry for help, but that can express itself in various ways. It could be a request for greater attention to actual physical symptoms. It could be just an expression of the person's way of expressing their grief. They may have fear of future physical symptoms, or they may feel like a burden on their family, or they may need reassurance, or they may be asking, it may be a question of sorts, asking for reassurance that the doctor will be involved till the very end. And this last one I found to be most interesting. And I'm not making this stuff up. This comes from the palliative care literature, an article by Susan Block. But sometimes a request might be a means of asking if I am still valued. Now that's interesting. And I've had this experience somewhat. I've never had somebody explicitly ask me for assisted suicide, but I have had people say things like, "Just put me in a corner," a patient with dementia. "Just put me in a corner." Or, "When I get bad, take me out back and shoot me." That's kind of asking if you're still valued. And what does it say to the person if you say, "Yes, I agree, I will put you in a corner," or "I will take you out back and shoot you"? So on one hand, the patient may be asking if they're still valued, and on the other hand, the doctor, by acquiescing to the request, is saying that the person isn't valued, that they are worthless. Now, obviously, not all requests for physician-assisted suicide are motivated by this. That's not my point here. But even if some are, you can understand how seeing and understanding the request to die would be very important. And it's difficult to explore that. Here's a case which illustrates that. This is a case which was published in the medical literature. And it shows us several lessons. Mr. Wazinski is a 36-year-old man with AIDS who recently stopped receiving treatment against HIV because of side effects. He lives with his partner near his family. He stopped working because he was too ill, but has remained active in AIDS education. So this guy does not give up. He's a fighter. He's a brave man. 10 years ago, he cared for his former partner who was dying of AIDS. So he also knows what the disease will do to him. He's been very open with his partner, family, and physician about his intention to end his life if his suffering becomes unbearable, and he has a severe peanut allergy, so that's how he would do it. Over the past several months, he's become blind and is wheelchair-bound because of HIV-related complications. His AIDS-related skin cancer is spreading, and he's lost 35 pounds. Nonetheless, he has continued to be active in his teaching activities. He's a fighter. One day, he comes to his regularly scheduled office visit, which is probably 15 minutes, or maybe 30 if he's lucky, to say goodbye and thank his physician for the care that he has received. And if this occurs anyway, like in my office, this would probably happen right as the doctor has his hand on the door to leave. He says that he plans to kill himself within a few days. Although he has considered suicide as a theoretical option, he now seems to have an immediate plan. The doctor explores his decision to end his life now and asks the social worker and the chaplain for their input. Although he is initially angry that the physician questions his intention to kill himself, his anger dissipates and he begins to cry when his doctor says, "We've been through this whole rotten disease together and I'm not going to abandon you now. We both know that your time is short, but I want to help you to have the best possible death you can have." Mr. Wazinski says he is tired of fighting and trying to be a role model. He is afraid of letting people down by giving up. He says, I never thought I would say this, but death has become my friend. I don't have the energy to get up and get dressed and try to put on a good face. With his agreement, the physician and social worker arrange a family meeting where these concerns are shared. His family and partner explain that they've recognized how exhausted he's become, but they've been afraid to encourage him to slow down because they did not want to demoralize him. After that meeting, Mr. Wazinski says he feels relieved that he does not have to work so hard to keep up appearances. He gives up his teaching engagements, spending his days in bed, and dies 1 month later. Now, we are in a large debt of gratitude to this patient who was written up by the name of Mr. Wazinski and his doctor who published this case, because this really helps us to understand how to help a dying person. And there's a lot of lessons here, so pertaining to assisted suicide, but also other things. The first is that the requests are complicated. So for all intents and purposes, this seems like the perfect assisted suicide. What better situation could you have? You have somebody who knows what the illness will do to him. He has a persistent and seemingly very rational plan for his death. It's not impulsive. His family is aware. It's a strong person. He's not the type that gives up. You would never think he was just doing it because he's giving up. He's not emotionally suicidal. So if anyone meets the requirements for a so-called rational assisted suicide, this man did. But really, there was an underlying cause even here. It takes time and resources to explore these things. Look at all the resources involved here. A chaplain, a social worker, a family meeting. I guarantee that wasn't a 15-minute meeting. This is not something that's possible to do for the standard doctor in a 15-minute office visit. A palliative care clinic has these resources, but general practitioners do not. For general practitioners, many times in their busy days, it would be easier just to write the script. But another equally important point is that experience is required to find the underlying cause for the request to die. This is not something that can be done easily. Now, if you're anything like me, you don't want conflict. You don't want a patient to get angry at you. And so when this man got angry that I was questioning his intent to die, I probably would have backed down. I would have been a coward. Naive and inexperienced doctors may take the request at face value, especially when the person challenges you. It's not easy to go against the patient's autonomy, especially in our culture where patient autonomy is so highly valued. But another important lesson here is the patients themselves are not always conscious of the underlying cause. So my hat is off to this doctor who didn't give in and very skillfully explored the request and found an underlying cause. And finally, like many cases, support for the patient eliminates the desire to die. People need support, not suicide pills. Many doctors are not experienced at exploring requests to die. And how do I know that? Well, there have been studies published of the Oregon experience with assisted suicide. And in those studies, over a 7-year period, 101 of the doctors, which accounts for 66% of those who prescribed any medications at all for assisted suicide, wrote only a single script over a 7-year period. So this is not something that they're doing very often. Now, you wouldn't trust yourself to a surgeon who was doing a complicated life and death procedure one time in 7 years without any certification at all. There's kind of a double standard here. So in New York, where I practice and where there's a proposed law for physician-assisted suicide, in New York, we have to do 3 hours of required training every 3 years in order to prescribe narcotic pain medications. We have to do a 4-hour course, educational course, if you want to prescribe medical marijuana. But under the proposed legislation and under the existing legislation in Oregon and other states, you do not need to have any training if you want to prescribe suicide drugs. And that's not even to say training about how to administer the medication or what dose to prescribe. You know, I looked up this topic and I found out on CNN, on the CNN website, that the medications need to be mixed in water or something like that, and you have to open the pills and drink them. I didn't see that in the medical literature. I'm sure it's there somewhere if you look hard enough. But my point is, no training is required on how to do this. And that's not even the worst part. The worst part, and the part that you really would need training for, is what I showed you in the case of Mr. Wazinski, how to explore these requests skillfully. And that's probably not the kind of thing you're going to get from a textbook or a 4-hour course. But the fact is, no training is required under these laws. So in summary, the wish to die is very complicated, and it's complicated to explore. It requires time, resources, and experience. And this is something which many doctors do not have. Under proposed legislation and existing legislation that legalizes assisted suicide, no training or certification is required for the doctors who prescribe the medications. This case that I present shows the art of medicine and how that will help the patient through his or her final days. And finally, understanding the complicated motives behind the request to die helps us to understand that if a person wants to die because he feels dignified, what does it say if I help him to do it? Physician-assisted suicide does not promote death with dignity, but death with indignity.